So, good morning or good afternoon, everyone. This is Richard Moss from ViewsIQ up in Vancouver. Would like to welcome everyone today. We've got I hope, very good talk by Dr. Gupta, who is going to talk to everyone today about his experiences, advice, thoughts about using Panoptiq to really help with improving and saving time and so on, preparing things and attending tumor boards, and how Panoptiq really helps do that. Dr. Gupta, are you there?
Yes, I'm here, Richard.
Okay. So I think we could probably get started now. What do you think?
Sure. Richard, before we start, would you like to just tell our attendees about the chat function we have? I believe they can use that to ask questions or just type in their experiences that might be useful to all of us.
Yeah, sure. So with the GoToWebinar, you have two options for talking or asking questions, I guess. There is the questions where you can type a question, and so we'll be watching that and we'll be able to get back to you with answers. As well as there is a chat section where you can basically chat with people, type a message, and you can choose to have that visible by everyone or just directed at Dr. Gupta or myself. So that, I think at the end as well, if anyone's got some questions, we could use that to talk about things. The other thing I think particular for the talk today is Dr. Gupta is going to be doing some examples, some demos using Panoptiq and how he uses it for using Panoptiq to show slides in tumor board meetings. So he has a set of example cases that he has on Panoptiq already. And so there is the handout with the slides today that you should be able to access. That's called example case links. And that has the actual URL links to those cases in Panoptiq that Dr. Gupta will be using today. So you can download that handout and then use those links in there to click on those to view the cases, to view the slides that Dr. Gupta is doing and doing the demo today about. And you can look along at the slides yourself while Dr. Gupta is talking about them. So I think with that, we could get started. So just a quick introduction. Dr. Gupta is currently working at MAWD Pathology Group in Missouri. He is one of the partners there. He previously did a residency in Detroit at St. John's Hospital in Detroit, where he was made chief resident during his residency. And then after he completed that, he went on to work at the Heartland Medical Center and St. Francis Hospital, both in Missouri, and was medical director at both of those. And for the last several years has been working at the MAWD Pathology Group, also in Missouri. My name is Richard Moss. I'm the CTO at ViewsIQ. Previously, I worked at McKesson, also in Vancouver, in their medical imaging group, in their PACS radiology imaging group side of things. And so I'm a relatively new convert to employee of ViewsIQ, and I'm very positive, very excited about the solution, the technology we've got here. So we will quickly talk today, I guess, in sort of four pieces. First, Dr. Gupta will talk about what is tumor boards and what are the problems that people face, pathologists face in tumor boards today, and how digital really helps with those. And then after that, I will quickly talk about Panoptiq, where we are today, some of the technology with it, how to use it, and so on, quite briefly. And then we'll also talk about what have we got out in terms of new functionality relatively recently, and what new functionality we've got coming in the next month or so. And I think that will probably be pretty exciting to people that are using the system today. Then Dr. Gupta will go through some example slides. So he's got 3 cases to go through there. And then after that, I will just quickly talk to finish off about some of the other options for using Panoptiq and how some people are using it for doing consulting services and second opinion reads today. So with that, give it over to Dr. Gupta, and he's going to spend a while talking about tumor boards and how that works in departments, what the problems are, and how digital fixes those problems.
Thank you, Richard, and a very good morning to our participants from the western half of the U.S., and a good afternoon to those of us from the Midwest and the East Coast. First things first, a slide didn't make it on this presentation that I just realized. I would like to disclose to all the participants that I do have equity ownership interest in ViewsIQ and also serve on the business advisory board of the company. So I just wanted to make sure that the disclosure was out there for all the participants to know about. Again, my name is Chakshu Gupta, and I'm a board-certified pathologist and lab medical director with MAWD Pathology Group. I'm based at Liberty Hospital in Missouri, which is a 300-bed community hospital with 5 outpatient clinics. The hospital offers pretty robust subspecialty services, including a regional cancer center. Today, I will discuss the role and advantages of digital pathology in tumor conferences. We know that the vast majority of patients are diagnosed with cancer in primary care settings and in community hospitals. Even in towns where specialized cancer centers exist, the management of patients with cancer is still predominantly done at community hospital settings. The American College of Surgeons believes, and most of us have recognized this with our own experiences, that a team approach involving doctors of multiple specialties and professionals offering ancillary services is associated with the best outcomes in patients with cancer. Next slide, please. Richard, may I have the next slide, please?
Yeah, do you see that? It should be the next one.
Yes, thank you.
Okay.
Now, at the epicenter of this team approach is the tumor board. The primary goal of the tumor board is to bring together this cancer care team and help improve the care and outcomes of patients with cancer. In my opinion, the primary goal is accomplished by exchange of important clinical information between the members of this team. Most patients would have presented to their primary care physicians first, or have had a screening test performed in outpatient settings, including some at employee health programs or health fairs. A follow-up test or procedure is often done elsewhere too. So I think it's very important to be able to review all pertinent clinical information at the tumor board to avoid unnecessary repeat testing and delays in patient care. I think the tumor board serves as a great forum to educate members on the most recent evidence-based guidelines on screening, diagnosis, staging, treatment, and follow-up of cancer patients. At our hospital, for example, we use NCCN guidelines in combination, of course, with recommendations of specialty medical societies, some of the prominent ones of which are the American Society of Clinical Oncology, or ASCO, and the College of American Pathologists, or CAP. I would love to know what national guidelines our participants use at their centers. You can use the message or the chat box at the bottom right-hand corner of your screen to give us some of your answers. The tumor board can also facilitate access to important supportive services, such as by involving the ancillary care providers. Now, these services are quite varied, but may include pain and symptom management, genetic counseling if needed, the often touchy subject of hospice and end-of-life care, and some centers may also offer financial assistance or planning and survivorship plans. So the primary goals of tumor boards are pretty comprehensive and really help us improve cancer care in our communities. Next slide, please. Thank you. Now, there are some secondary benefits of tumor boards, the most important of which I believe is quality assurance. See, most cases are presented at tumor boards. They undergo review of their pathology material and radiology images, often by a different pathologist or radiologist, respectively. So this is a person, a professional who is other than the one who initially signed out a case or reported on the CT scans or X-rays or whatnot. This is a great peer review process, and I think it provides important information on the quality of pathology and radiology services at your institution. There is also an opportunity to review and assess cancer screening effectiveness in the community. As an example, if at the tumor board you begin to notice a lot of breast cancer patients where patients first presented with palpable masses, you may need to address screening mammography in your community. The management plans can also be reviewed to ensure compliance with nationally recommended protocols, such as NCCN, and access to supportive services. If available, patients can be enrolled in research trials via the tumor board. This information is also helpful to the cancer registry of your hospital. And finally, I believe the tumor board serves as a great forum for medical providers, both physicians and non-physicians, to come together in a semi-formal setting and develop a working relationship, and of course, feel part of a care management team. Next slide, please. Now, traditionally, pathologists present their findings in one of two ways. The most common way, in community settings at least, is still images captured prior to the tumor board. So the pathologist selects and marks important areas on glass slides and takes pictures using a camera attached to the microscope. However, this process only allows for limited findings to be presented. Most cameras cannot even capture the entire tissue section on the glass slide. So and then once you capture those images, you need to import these images to another software, such as Microsoft PowerPoint, for example, for adding text, annotations, and finally, to present at the tumor board. I believe that these still images are not as effective, and really, they also don't have any future use. So a lot of hard work that pathologists do prior to the tumor board essentially is ineffective and certainly does have very limited future use. Now, the second most common way for pathologists to present at tumor board is to take a stack of glass slides and use a camera attached to a microscope in the conference room and hooked up to a projector to display images. Now, these quote-unquote live images still need to be reviewed and marked prior to the conference, and this setup is quite expensive and quite honestly cumbersome. I have seen pathologists scatter to find the right slide in response to a question from an oncologist or a surgeon, and the moving images, since they're being projected while the pathologist is moving the slide on the microscope stage, often going in and out of focus, it makes non-pathologists a little queasy. Next slide, please. Richard, may I have the next slide, please?
Yeah, that should be there.
Thank you. Now, digital pathology, in my opinion, is like moving from your old rotary phone to the latest model of a smartphone. You can very easily scan all the relevant glass slides using the scanning software that is provided by ViewsIQ. And this software lets you scan the entire tissue section or sections, if you have levels, enabling a very comprehensive demonstration of the pathology. You simply, and for most of us very intuitively, move between magnifications or areas of interest with the mouse or the keypad. The ViewsIQ software also allows you to demonstrate related structures of findings very nicely. Think about the time when the surgeon believes they got around the tumor surgery and you reported a positive margin. Now you can very easily, by clicking and dragging the image, show how the tumor has maybe an irregular growth pattern with irregular margins and a tongue of tumor that projects from the main tumor mass and is present at the margin. I think it would take multiple still images to show the same finding using traditional methods. And in most cases, you probably would not even have taken all those images during your prior review. With digital images, you can show features that were not previously captured in still images, but that were brought up during tumor board discussions. You can share the entire file via email or text using a URL link. It's very easy, and Richard will demonstrate how to do that. Digital images are very favorably received by the tumor board members and can be used for archiving cases, for education, for peer review, and for consultation. And with this, I will hand over the microphone to Richard, who will tell you a little bit more about these options. And once he is finished with that, I will then go over some example cases that I've used myself at my hospital for digital pathology at tumor boards.
All right, thanks, Dr. Gupta. So Dr. Gupta really, I think, outlined a whole bunch of advantages: clinical, organizational, scheduling time, finding time to do things, advantages of going digital. It obviously has a lot of advantages. One thing I would like to mention and extend on that is the ability for digital to give you images that you can share with anyone. And that is something that obviously, as Dr. Gupta was saying, is done by sharing a URL to someone that Panoptiq gives you. This allows you to share your slides with anyone, anywhere, anytime. Your tumor board members now can look at the slides that you want to present during a tumor board, both during the meetings as well as after the meetings. They have a URL. Anytime they want to review the slides, they can do that at home, in their office, or during the meeting itself. But that's not only restricted to your tumor board members, the whole care team can do that as well. If you have residents, your residents can look at the slides as well, so you can use them as a teaching resource as well. And your colleagues can look at those as well. So this is really extending the benefits of going digital simply from a clinical time advantage to extending pathology and the pathologists out into the enterprise and the community. You are now able to share your expertise, your influence, and so on outside of the department, because you have the ability to share your slides to whoever you want, whenever you want. So in light of that, I'll just go over some of the latest changes that we have introduced in Panoptiq Portal and the Panoptiq Scanner. On the portal side of things, we have introduced a lot of features lately and done a lot of work to improve the usability and the speed and the stability. We're really focusing here on having a system that allows people to quickly and easily use digital slides in getting their job done. And we've introduced, the first of a set of training help material in the portal as well, which is a new user introduction movie right now. And this is really focused on that idea as well, getting people up to speed and making it as quick and easy for people to use the product so that the product doesn't get in their way. It's not a barrier to people using the slides, which is really what you want. On the scanner side of things, we've just recently introduced a new package for the installation that basically gives you a way to go and have a single-click installation of the scanner. I guess many of you are users of the system already, and so you're probably aware that this was a long and time-consuming process previously. And again, focused on making things easy and usable, we have done the same thing for the scanner as well recently. So just to give you a quick overview of this new movie, this is available now in the help menu, basically the 3 dots menu in the portal right now, called Introduction. And I'll just give you a quick view of what this introductory movie is for new users. And I hope you can see this now. This is really a quick couple of minute introduction to how to use the system for people that have never used it before. And in light of, using Panoptiq as a solution to go and share your slides out with your colleagues, with residents, perhaps to GPs and so on. This is a solution that lets people get up to speed and know how to use things as fast as they can so they can concentrate on your slides. So now also talking about what is going to be coming soon, and what I'm talking about here for soon is in the next month or 6 weeks or so on, we have a couple of really interesting, very exciting things that we're going to be doing. And I think people who are already using the system today will be pretty excited to hear about this. On the portal side of things, we will be adding case and slide notes separate to annotations, and I'll give you a quick peek at that in a second. And we'll be allowing you in the portal to upload and have with a case associated case information. So you could use that, for example, for things like tissue photos, pathology reports, any related radiology images or radiology reports. You could really use that for whatever you like. So that's for the portal. Now for the scanner, we will be having, I think, a couple of changes that will be very, very welcome by people that use the system today. We will be doing a complete UI overhaul of the scanner, really focusing on making the technology something that is quick and easy for people to use to create slides in the first place. And as part of that change, we will be introducing a feature to go and say, in the scanner itself, a single button, a single click, once you have a slide digitized, to upload that to the portal. So to give you a quick overview, a quick view of that, here is a picture of what is in development right now, which we expect to have out in the next 2 to 3 weeks, of the new Panoptiq scanner. So this is what we are using for the new user interface for that. I think, for people that know the system now, this is obviously a much cleaner, simpler, faster to use user interface, and very much taking after the portal user interface, so that we've got one system to learn, one system for you to use. And as part of that as well, we will have a single click within the scanner now to say, okay, I'm done, this slide is ready, send it to the portal. In the portal itself, we will be adding case notes. So we will be adding the ability for you to go and associate a note with the case as well. So you can use that for anything you like, but you can use that as a communication tool for consulting, for notes for yourself, or taking a slide to a tumor board, some notes to give the tumor board members about the slide. There are many ways you could use that. So you can create a note, and then when you open a slide in the portal, it is visible to anyone who can open that case. So with that, now Dr. Gupta will walk us through some examples of using portal, using Panoptiq today for tumor board. So again, just to reiterate, there is the handout with the presentation today. That's called example case links. And if you download that, it has these actual URL links to these cases in that. So you can click on them and actually open these cases yourself in portal to follow along today.
Okay, thank you, Richard. Before I start with my first case example, is it possible for me to gain control of the link?
That I'm not sure. We could try.
So while Richard is activating that, let me tell the participants a little bit about this case one. This case example is from a young patient in her early 30s who presented with fairly non-specific clinical complaints to her primary care physician. And the sum total of their examination and subsequent investigations resulted in what they initially thought was a thymic cyst. So the patient was then referred to a cardiothoracic surgeon who looked at the scans, confirmed what they clinically thought was a thymic cyst or a cystic lesion, and and then proceeded to to excise it during surgery. So this is a representative image of what we received in pathology. And the first thing that strikes you is that this is not a very cystic lesion. It's actually pretty solid. Now, when I present my cases, some of the things that I would like to point out to the members also is the difference between what I could have done with the traditional way of doing things and the digital way of doing things. Now, in traditional cases, if I had a camera attached to a microscope that was taking still images, there was no way that I could have shown this wide a field of tumor, and this is predominantly a solid lesion. So that's something very important to convey to the surgeon. So this was a solid lesion. And let me see if I have control over the images now. Yeah, there we go. So what this lesion is, obviously you can see there are some areas of blue and areas of pink. So this has a lot of fibrosis and a lot of lymphoid tissue. Here's some fat, and I'm sorry, there's a little bit of a lag between when I go between levels and what happens on the screen, so please bear with me, but this process is fairly seamless during tumor board presentations because the images are either on the web, on the cloud, so to speak, or they're on your local computer, so it's very seamless. But again, multiple nodular areas composed of lymphoid tissue and a lot of dense fibrosis. And then we will move from there and go into higher magnification. To show you some of the morphology of these cells. This did turn out to be a Hodgkin's lymphoma of the thymus, which is a very interesting lesion by itself. And okay, there we go. We'll give it a few seconds. To come into focus. So this is a very interesting lesion. It actually does present predominantly in young female patients and can very easily be missed because it can be asymptomatic. But other than that, the morphology of the thymic Hodgkin's lymphoma is pretty classic for any other Hodgkin lymphoma in any other structure or site rather, in which these large cells, the classic Reed-Sternberger Hodgkin cells, admixed with a background that is composed of mixed inflammatory infiltrate. And in this particular instance, the cells were pretty classic. They were large, often had one or more nuclei or nuclear lobes with prominent nucleoli. Just waiting for the image to catch up with my presentation here. As you can imagine, this computer is in Vancouver, and I'm in Kansas City, so it takes a little bit of time for the images to get to me and for my clicks to get back to Vancouver. But anyway, so this is the classic morphology of this lesion, and once you start looking at these images, you can practically see that it's a very classic morphology of Hodgkin's disease. This is the advantage of having digital pathology. First of all, I can show at low magnification as to how the tissue was, and then I can zoom in, zoom out, move between areas, show them salient features of the tumor. You know, someone may just ask a question at a later stage, and it's very easy for me to go back and forth. And what I'm going to do next is, as soon as I can get the image to click, I want to go back to the cases and show you some immunostains that I performed on this tumor. Richard, would it be faster if you were to do the actual, if you were to actually open the images for me and drive as I speak? Because it looks like there's a little bit of a lag between when I click and what happens on the image.
All right, so this is the next slide in that case here. So if we open that one now. All right. So can you see that now, Dr. Gupta?
Yes, thank you, Richard. And to the participants, this is a CD30 immunostain that I performed on this lesion. And again, the background fibrosis and mixed inflammatory infiltrate, you can see in the light blue background tissue color. And then, of course, there's a lot of brown. Richard, if you would just select one of those two areas, marked areas, and go to higher magnification, please, for me.
Gotcha. There we go.
In any of one of those two boxes.
Mm-hmm.
Wonderful. And yeah, wonderful. There we go. And as the participants can probably see, this is the cells of interest staining very positively with CD30, very classic. It's the membranous and cytoplasmic sort of staining with the nuclei being negative. So this is CD30 stain. It was diffusely and strongly positive. And Richard, can you go back to the third image now in this case?
Okay, sure.
That I believe is of PAX5 immunostain. And for those of us who are non-pathologists in the room, PAX5 is a very, very helpful stain in Hodgkin lymphomas. And the reason is this, that PAX5 stains weakly in the neoplastic cells, but strongly in the background B cells. And again, Richard, go ahead and click into one of those boxes. And we look at the neoplastic cells of interest. So it's a very interesting stain. It helps highlight those cells better because the background, so remember the background has these mixture of T cells and B cells and eosinophils and all these inflammatory cells, so it really helps. And you can see here, go back to that magnification, Richard, that was perfect.
All right. Zoomed in or zoomed out?
Sorry. Yeah, zoom in just a tad bit more.
Oh, okay.
So, so these little dark dots in the screen, they'll come into magnification in a little bit. These are the background B cells. And actually, the larger cells, okay, excellent. I don't know if the participants can see my cursor as I move it, but oops, sorry. Just keep it there, Richard. So these larger cells that are faintly positive, these are the neoplastic cells of interest. I wish I can find a good cell to show the part. I believe this might be one of those cells. Richard, go up magnification, up one. I believe these are some of the cells right here. They're faint, but they're larger cells. And the darker cells, the smaller darker cells are the background B lymphocytes. So a very classic case of Hodgkin's lymphoma, except it involved the thymus in this case, a very interesting presentation. But the use of digital images really helped me drive home the important salient pathology features of this case that I believe I would not have been able to as effectively demonstrate using glass slides. Let's go to case 2, which is an equally challenging case. It's not a very uncommon case like the first case, which is very uncommon. Case 2 is perhaps a little bit more common in community practices. However, there we go, thank you. However, and keep it here for a second, Richard, or that's fine, yes, there you go. So here's the deal. This is a low magnification image demonstrating almost the entire section on the glass slide. There is no way, well, sorry, I apologize. I want to tell you the participants, this is a picture of a dilated appendix that was taken out for clinical diagnosis of acute appendicitis. The appendix turned out to have a mucinous cystadenoma of the appendix. It was pretty much dilated, as you can see in this image, with thinned out walls and mucin and a little bit epithelial proliferation lining the lumen. Now there was no way I could have shown this immense dilatation and thinning of the wall using a still image, at least not this effectively. Can you go to one of those areas, the boxes, Richard? Now, these cases, since the appendix is stretched out and so thin, it is very difficult to actually be able to take a lot of still images to demonstrate the findings. But with digital pathology, just by this one scan, I can demonstrate the stretched out dilated lumen, the thinned wall, and here the lining epithelium. Let's go a little bit higher magnification on the epithelium now. So the participants can see how the lining epithelium There we go. Excellent, excellent. So there is a little bit of proliferation. The nuclei are a little bit larger. They're more elongated, more pseudostratified, and they have all the morphologic features of a very classic benign mucinous cystadenoma of the appendix. Again, not a very uncommon lesion, but exceedingly challenging to take still images of and project them on tumor boards. So excellent. Let's go to case 3. Case 3 was an excisional biopsy of a retroperitoneal mass. It was sent to us as a mass in a patient that had no specific clinical issue, so there was no lymphadenopathy or tumor masses that they could see, but the patient had presented with some CBC abnormalities. There was a subsequent workup performed, and go back to low magnification, Richard. I'd like to show the participants a feature that actually I had a great trouble showing with low mag. There we go. Thank you. Thank you. Just keep it at that for now. So this is the scanned image from that material, from the retroperitoneal, which I believe is a lymphoid mass or matted lymph nodes, maybe even. So what I can show using the digital pathology images here is, number one, effacement of normal nodal architecture. That's almost virtually impossible using still images taken from a microscope camera. Second of all, I can show that there is a nodularity. Now go a little bit higher magnification, Richard, maybe by 1/4. Don't go in that square yet. Just on this low magnification, there we go. So the most important part of this image, which is exceedingly, thank you, that's perfect, keep it, are these nodules. I hope the participants can acknowledge these nodularities. And this is exceedingly important because when I asked Richard to go to higher magnification in that box, Richard, what you see are large cells, and these large cells stained positively. Yes, these large cells, and you can go ahead and magnify that area for me, Richard. So these large atypical cells stain positively with CD20 and CD45, both of which are B cell markers, and they were negative with CD15 and CD30. So in these cases, unless you observe the wonderful. Unless you were able to go up one more magnification. So unless you were able to acknowledge these nodular areas, you'd be hard-pressed to give the right diagnosis. So the differential in this case, of course, is a diffuse large B-cell lymphoma, a much more common lesion with the same immunoprofile and almost similar morphology. But this case, because of the presence of nodules, which I could very effectively demonstrate to my tumor board colleagues, this is actually an example of nodular lymphocyte-predominant Hodgkin lymphoma. And quite honestly, between that and diffuse large B-cell lymphoma, again, so for pathologists, we have different criteria, but when I'm presenting this to my clinical colleagues, you have to remember I cannot become too technical, right? So I need to show them that although this entity stains very much like a diffuse large B-cell lymphoma, it is the presence of these large atypical cells along with these nodularities that actually moves it from the diffuse large B-cell lymphoma category to the nodular lymphocyte-predominant Hodgkin lymphoma category. This distinction is exceedingly important in management and treatment protocols between the patients. The treatment is different, the management is different, the prognosis is different. So again, I hope that these 3 examples, which are real-world examples that I did present at my hospital tumor board, can help you appreciate the advantages that digital pathology can bring to the table. In addition, I have kept these cases, the first and the third case, as teaching cases for my students. I am a clinical preceptor for a local university in Kansas City, and they have a medical school as part of the university, and we have third and fourth year medical students often want to come and do a rotation in pathology. So they come visit me, and of course, when they're here for a few days or a few weeks, even a month, I'm in a community practice, so I don't get super exciting, difficult cases on a daily basis that, sometimes we get a bread and butter appendices and gallbladders and so forth. So it's just so easy for me to pull up these cases from my archive and give the medical students, and sometimes I even have residents, of course, give them a very comprehensive review of pathology of really these exciting, somewhat unusual, maybe uncommon cases. All right, Richard, with that, I hand it back to you.
All right. Thanks, Dr. Gupta. And apologies to everyone. We're trying to do a remote webinar out of Missouri, driving the computer here. So I hope it worked for everyone. And again, those the links to those URLs are in the handout. So would welcome everyone who is in the session today to open those cases themselves. And then obviously you can explore the slides yourself rather than us having to do it for you. Okay, so I'd just quickly like to talk then about using Panoptiq today outside of tumor boards in a different situation, which is for consulting and second opinions. So typically most organizations, most pathologists want to do consulting or are involved in consulting second opinions in 3 different situations. Those are really, you're working in an organization, or perhaps you yourself are providing consulting services to other organizations or other pathologists. Or you have a case and you want to get a specialist expert opinion on that case. So you're looking for an external pathologist to give you that opinion. Or you're in a situation where you have a patient transferred into your organization that's got pathology done somewhere else, and you are wanting to review that pathology prior to surgery. And in that last case today, often I think in many cases, you have to get new slides cut at the remote location and then get those basically transferred in so you can have your local pathologist review those as well. So in light of that, in light of consulting and second opinion type reads, that sort of thing, I'd just like to basically run through today comparing Panoptiq with whole slide scanning based solutions. And again, if you think back at the slides we just looked at that Dr. Gupta just walked through with all of you, you should remember those were created on Dr. Gupta's own microscope. You can create slides like that with the same content, the same image quality and so on your own microscope in a minute or two. And obviously if you're doing the review of the slide at the same time, you can use Panoptiq to just go and basically piggyback on you looking at the slide to record what you're seeing. And it basically is something that is very quick and easy to do, and that's our goals there. Now, how this will work in a consulting situation is, well, obviously, as Dr. Gupta said, the first thing you need to do is get slides digital. You really could do things the old way, and if you want to get an expert opinion from someone else, if you want to do consulting from someone else, you can still ship glass around if you want, but that's not really practical today. So whole slide scanners are a way of doing that, obviously, and Panoptiq is a way of doing that as well. So if you compare just the step 1, getting things into a digital form today, with whole slide scanners, obviously, that is very expensive. And there is usually a lag time. Once you've got some money and decide you want a whole slide scanner, you then have to wait for something to be installed and then training and so on before you can get up to speed on using it. And they're, inherently complex systems, and they're something that is new for everyone at a department, another system that is quite complex to learn. With Panoptiq, in contrast, you're using your existing microscope. And with our UI changes that I previewed today, we're really making it basically, 1 click, 2 clicks, okay, I'm done, send to the cloud. That is our goal, to make getting your slides digital with your own microscope that easy. And it's something that you could basically have installed next day. You need a camera on your microscope, download a bit of software, and you're up and running. Apart from getting the slides digital, there are a couple of other things that need to be done. Obviously, in a consulting situation, you want to scan the slides, but then you've got some digital files, and you want to have someone else look at those. So you need those digital files transferred, from the external organization, from your client to your expert pathologist. With a whole slide scanner, it will get you some digital files, but then how do you get them? How do you get someone else in a different location to look at them? That is another problem to solve. You know, you can FTP them, you could use Dropbox, you could perhaps try and email them if your email client supports very big email attachments. But with Panoptiq, that is essentially automatic. You can scan a slide, press upload to the portal, and it's there. All you need to do is send someone a URL, and they can look at the slides straight away, basically as soon as you finish scanning them. Another issue, I think, with pathology today, and you know, again, coming from my background in radiology, this is like radiology from 20 years ago, is that there are all these proprietary formats and systems out there today. And, you know, this is, I think, prevalent with whole slide scanners. And if you're doing consulting, if you're doing second reads, this is very hard because you don't know, well, which system do these slides come from? Do I need to use application X, Y, or Z to open them? You know, do I have some local software that can read these files? You know, everyone is doing their own thing. With Panoptiq, if you are giving files out to someone or you are looking at slides from another location, you just have a single system and a single interface to use. You know, and again, it's also very simple. That's, you know, one of our design goals going ahead is make things very simple and easy to use. With whole slide scanners, you do have to, you know, consider and worry about the image quality and the content. Did the scanner do a good enough job or not? As well as you are limited today in the maximum magnification that a scanner will let you do. And of course, with Panoptiq as well, we've got our Z stacks that basically give you the full 3D view through the slide if that's what you need for a particular case. And that's something you can't do with whole slide scanners today. So from an image quality and content perspective, you know, we are better than scanners today. And then the final point is communication. You know, obviously, if you're doing consulting or if you're looking to seeking a second opinion and so on, you're looking to communicate. Well, first off, what is up with this slide? Why do you need someone to look at it? And then what are their thoughts? What's their findings on the case? They need to communicate those back to you. With a whole slide scanner, it's not a solution. It's not a system that provides anything around communicating back and forth. So that's another issue you've got to figure out. You know, do you call someone? Do you email them? What do you do? But again, with Panoptiq, and this is referring to the new case notes feature that will be out in the near future, that has a built-in communication mechanism. If you want to share some slides with someone, another pathologist, for them to look at it, you can write in there, okay, here is why and here's what I would like you to look at. And then they can put into the portal their findings. And so you don't have to worry about separately another issue. How do we communicate why the slides need looking at and then what the findings are? That's, again, built into the portal. So from a consulting perspective, you know, whether you're doing consulting, whether you're seeking external consulting, or you're in a situation where you have an analogous situation, you need to review slides for a patient transferred in from a different facility. Using Panoptiq today, the combination of the scanner and the portal together really gives you a solution that, you know, lets you, at a very low cost and in a very fast time frame, get you all the clinical information you need. And, you know, it has a lot of advantage over whole slide scanner-based solutions today. So with that, I think that's the end of the talk today. So I would hope, you know, if people have some questions, they could take some time to ask them now. Dr. Gupta and I are quite willing to answer any questions you've got. Or apart from that, my name is Richard Moss. Again, it's in the introduction of the slide. So you could email me, which is very easy. It's Richard Moss, all one word, at ViewsIQ.ca. And, you know, if you would like to follow up more with Dr. Gupta about his cases, I will be able to put people in touch with him as well. And again, in those case notes, you can open up those cases directly in Panoptiq yourself and review them as well in there. So I hope that was informative today, and I very much like to thank Dr. Gupta for his time today. And I hope as well this is something that is both educationally, clinically to the people on the call, and also is helpful in terms of letting everyone know today where we are focusing and where we are looking to go with the product. And that is really making it a system that doesn't get in people's way when you want to use it. We want to make a system that lets people look at slides digitally, lets people share slides digitally as easily and as cheaply as possible. So thanks for everyone's time today, and would welcome any questions.
Thanks, Richard. And while we're waiting for any potential questions, I would like to thank the team at ViewsIQ for hosting this very informative webinar. I certainly enjoyed being a part of it. And the three cases that I presented, like you mentioned, those URL links, they are open for anybody to try out. They can click the link, and it will take them directly to that case. And they can see how seamless it is to sort of go through the case and be able to zoom into those areas of interest and see the findings for themselves. I've been very happy. I've had this since summer of this year, I believe, early summer. So my clinicians have been very happy. My students have been very happy with this, and I plan to start using this for my intra-departmental peer review soon. Just waiting for that new web portal you mentioned, in which you can do a single-click upload to the to the cloud, and I plan to use that for peer reviews. There's a host of applications for the service. I also remembered, as you were talking, Richard, that I met a gastrointestinal pathologist who has a consultation service in which he will only look at digital images. He will not. So if you send him mail him a set of glass slides, he'll have his people actually scan them digitally and only look at digital images, and then he'll incorporate those images into his consultation reports. So there's something out there that this has truly been tested and been used in the real world.
Yeah, I'm just looking at a couple of questions. There was one question about how long does it take to scan a slide today? Typically, it would take you 1, 2, or 3 minutes or so on to scan a slide. If you're not looking from it needing regions of interest where you want to scan at a higher resolution, let's say some regions at 40 times, 60 times or higher. But typically what is easily achievable is if you want to do a scan at 10 times, let's say for a cytology slide, that will take you less than a minute to get the overall slide scanned. And then if you want to scan a couple of regions at a higher magnification, that is something that only typically takes less than a minute for each region as well.
So I would agree with that, Richard. And in fact, there is an advantage to using Panoptiq over a whole slide scanner, for example. Kind of goes back to this question. Number one, with a whole slide scanner, you have to scan the entire slide. Once you put it in and you shut it, it'll scan the whole slide. With Panoptiq, you can choose how much of the slide you really want to scan, because not all the time the entire slide or the section on the slide is of importance. That helps you, number one, in a more quick review of pertinent findings. Number two, you can quickly hone into the areas of interest and scan those at higher magnification, or even choose to email or send them via link. Second of all, it helps you with your storage type issues, because whole slide scanned images require a phenomenal amount of space to archive and store. But with Panoptiq, you have an option, because you only scan the amount that is of interest and of use to you, whether it's clinically or research or consultations or what have you. So you can limit the amount of file size and the time, therefore, it takes to scan these.
Yeah, and I think that your comments there relate to the second question, which was, what is the average size of the scanned image, and what type of storage are we using for them? The size of the scanned images depends very much on the user, as Dr. Gupta said. They are obviously a lot smaller than a whole slide scanned image because you can only scan the regions of interest, the clinical regions of interest at a higher magnification, while the rest of the sample, the rest of the slide is done at a 4 times or 10 times magnification, just so you can see the overall morphology of the sample, at a low magnification, which is all that might be clinically needed, clinically relevant in that case. So typically, our slides are on the order of 100 megabytes or so, 200 megabytes. But again, it does depend on the user. If you want to scan a sample at the entire slide at 40 times, you can do that. And we will obviously have larger files. But in use, typical clinical use of the system, the files are, let's say, 50 to 200 megabytes. And mentioning that as well, that is also including in that size if users are going in there and creating any of our Z-stacks, which we didn't demonstrate today, but if you look in the portal in the introductory video, you can see some Z-stacks in that and how they're used. The Z-stacks basically give you, a full continuous depth view through a sample, through a slide, in a very space-efficient and time-efficient fashion, and is something that is not even technically possible with a whole slide scanner today. The closest you might do is, convince a whole slide scanner to take 16 individual slices, but that is still nothing approaching a sort of continuous view, and it obviously makes your whole slide file 16 times bigger. So, we're very space efficient there, but obviously with an advantage of having a continual 3D view through a sample.
Richard, I would add that the Z-stack really is only essential for either a peripheral smear case in which you have to focus in and out of a specific cell, but more importantly for cytology slides. I think for the overwhelming majority of anatomic pathology slides, mostly surgical pathology and even peripheral smears, bone marrows, you don't necessarily need Z-stack scanning for a majority of this area of interest. So I think we can use this to limit both the scanning time and the size of the scanned image.
Yeah. There was one other question so far, which was, do users have to pay for the cloud storage cost? Or could a customer, could a university, for instance, use their own servers to store the images? So right now, the system uses, when you buy a Panoptiq license, we give you some cloud storage for storing your slides included in that. And so that is, stored in the cloud, and that's included in the cost of the system. We don't today support the situation where a university, for instance, might look to use servers at the universities to store the images themselves. There are some options we can do there, and we do have some technical options there for doing things for particular customers that we are exploring with people. But typically today, we have the storage for the system all being on the cloud, really with an idea that, that is a very cheap and low cost way of doing it, obviously figuring maintenance and so on in there. But also from a sharing point of view, storing things out on the cloud really optimizes the performance for people looking at those slides wherever they are located. So it looks like there's no more questions. So again, I'd like to say, from me, thank you for everyone for attending the talk today. I hope it was educational for everyone. And also to mention that CAP is coming up it's a week and a half now in Las Vegas, and we will be there. So anyone who is at CAP is very much welcome to come by and say hi and have a demo and have a look at things. And our booth at CAP is booth 201.
And Richard, for everyone who comes down to Las Vegas and attends the CAP 2016, I'd like to remind them that whatever happens in Vegas stays in Vegas.
Yes. It's a very good
Well, thanks,
town.
everybody. I really appreciate
Yeah, it's a very good town.
really appreciate all the attendees that spared the time to listen to us and see some demonstrations. Again, if there are any follow-up questions, we're very happy, both Richard and I, to answer those. We'll do our best to answer them. And again, thank you and have a wonderful rest of your day.
All right. Thank you, everyone.